Welcome everyone to the VITA Learning webinar with Peter Pizzi today. We are going to have Mr. Pizzi, who's a Master Dental Technician, go over quite a few different topics today. So we welcome all of you that are interested in learning, enthusiastic still about the industry, and enjoy today still watching some webinars, remote learning. It's the best way we can do it today since we're not really in person across the United States. The program today is going to be with Peter, as I mentioned. Peter, of course, has been in the industry for, how many years have you been there?
Too many years.
Too many years. But he is like I said, mentioned, a master dental technician. So he does everything at his laboratory. He gets into zirconia, into pressing, into PFMs. You know, still that's a viable solution for a lot of dentistry today and patients. And Peter will go over some of that stuff. Just a few things that we want to go over first. And kind of like some house cleaning, if you will. And that's going to be your phone. All of you are going to be on mute. There is a chat or a question box actually in that drop-down box that you have on the right-hand side of your screens, everyone's screens that's viewing. You'll be able to ask questions through that box. If there's something that you want to know at that specific time, just type in, send them to me, and I'll interrupt Peter like I always do and give him a question. Otherwise, at the end of the program, we're going to have a block of time there for Q&A, just you know, anything that's been tabletopped, if you will. The webinar is going to be recorded. So some of you don't catch some of this stuff, you can always visit us on our VITA Learning website. And then those of you who are asking about CE, you're going to receive an email after the program, and you'll have to respond to it, and then you're going to send that back to us, and then you'll be able to get the CE information. I'll cover that again at the end of the program. But again, welcome. Today's topic is case management and material options with Mr. Peter Pizzi, and he is going to blow you away today on all the information that you need to know to help treatment plan, talk to your dentist, discuss, find out what's best for the patient to make everything as good as can be for, obviously, for great smiles moving forward. So I'm going to now, Peter, I will turn it over to you.
Thank you, Jim.
And you are the presenter.
Okay, you have my screen? Let's see. You now have my screen, Jim?
I do.
Okay, great, thank you, and appreciate it, Jim, very much. So yes, as Jim said, we're going to run through a lot of information in a short period of time. And the way I built this program is really to go through exactly what we talked about, and that was really case management and material options. Obviously, in 1 hour, that's a lot to cover, so I'm going to go through this kind of quickly. But the beauty of the good aspect of webinars and being online in some ways, even though there's a lot of negative for me, some of the good parts of it is we can break these down differently. So please feel free as I run through this, and you'll see it's kind of a wide spectrum. You can email Jim or be in contact with anybody there and suggest, hey, I'd like to hear specifically more about this or specifically more about that, and I'll gladly break it down for you. As Jim said, for me, I can honestly tell you I'm kind of tired of the webinar scenario. I'm sure some of you are too. I miss being in person. I'm jonesing more than probably everybody even realizes. For me, I spent 3 weekends a month for the last 5 years traveling around the world in different places, and And to not be able to do that this last year has been hard on myself, and I'm sure on many other people in many ways. This is just one little area of it. So I do miss it. The good news is I do think it's starting to ease up a little bit, and I know I have some travel dates coming up starting at the end of March and April, and fingers crossed that we'll all start getting back to a more normal life again. Besides for being in a lecture space, which obviously for me is a lot of energy and time it goes into, I think what I miss even more than that is the closer interactions, being able to sit down and really talk through things with my fellow technicians and the dentists that come to the programs that I'm doing. So that's such a challenge, I think, today. And you know, it's funny, Jim and I did a program yesterday for a laboratory in Canada, and I have to say it's so difficult because those are usually hands-on, where we're behind the scenes and I get to see exactly what's happening. But without sounding like I'm whining, I'm excited for the future, because I do think that this does give us options to do more, but also I feel like time's passing, and I know I have dates and things that are growing. So I look forward to seeing more people in person, hopefully soon. When I start to talk about materials, for me, materials I drive based on these three words that you see on my screen here. What is the functionality of the patient? What is the aesthetic parameters that we really need? And then what is holding the restoration? Is it going to be implants or natural teeth, right? What is the abutment, as we would say, that's going to be holding it? So for me, these three things are how I look or break down my material options. I don't do it kind of the way the industry has presented it to us. And I'll go through that a little bit with you. What do I mean by that? Well, the industry has been really great at talking about the product and process point of view. How fast can we make it? Is it milled or printed? Is it a manual technique? And how strong is it? Is it 15,000 megapascals? Does it break easy? It's the number one question I get. I mean, when I'm lecturing to dentists and technicians, I can't tell you how many hands come up and say, how strong is it? How hard is it? And without sounding too rude, I'm sorry, I'm a New Yorker, so I'm sarcastic and rude sometimes, but without sounding too rude, it's such a silly question. It's almost, you know, the saying, oh, there are no silly questions. That's a silly one. And the reason it's a silly one, because we've been so brainwashed into thinking that hardness is the only thing that we should be concerned with. And it's not. Matter of fact, it's one of the last things. So as much as people are spending time talking about the products and the processes that we use, I want to focus always, and for those of you who know me know this already, on the people. Those people are mothers, brothers, fathers, sisters, and uncles, and our job is to take care of them and help them. And it's not to just say, I'm going to put something that's 8 billion megapascals in your mouth and it's never going to break, so you don't have to worry about it again. Because then you're not really looking at the big picture. You're only looking at the immediate band-aid of a fix. And we have to make our decision about the people or the humans that we're working on, and how to really evaluate through them. So when I start looking at my cases, and if you look at the photograph on your screen, this looks simple, doesn't it? This patient has an ugly tooth. The number 9 or the 2-1 doesn't look correct, and we should change that. But is that really all there is to it? And again, first question that would pop up is, how strong is the material you're going to replace it with? I don't look at it that way at all. What I'm actually looking at is, I need more information, because that picture alone isn't going to give me enough. It just tells me that one of those teeth are improper. Actually, it tells me that several of them are improper, right? I hope you notice right away that that lateral is not a lateral, it's a cuspid. It's been moved into the wrong position. So that's an orthodontic challenge that we face. Also, there's chipping on the number 8 or the 1-1. How did that happen? And how do I know that's not going to happen to my new restoration? Also, the gingival architecture is not in the right alignment. So all these things start popping through my brain. And what I really need to figure out is, what does it look like in the face? Because that's where it really matters to me, is seeing the human and seeing that part. And by the way, the eyes never lie, which is why I say, you know, these meetings are slightly frustrating to me, because I can't see your faces. I can't tell if you're getting it. If those of you who have seen me before lecture, you know, I kind of run around the entire room the whole time. Why? Because I like to see your face. I like to know if you're paying attention. I like to know if what I said made sense to you. And if it doesn't, I can kind of see in your eyes that maybe I need to spend another minute or two diving into that topic to explain it better so everybody grabs onto it before we leave. Well, it's the same with us for our patients. I can look at that face and say, that's not a happy patient. Look at his eyes. Look at that awkward smile where he doesn't even know if he wants to raise that lip all the way up as he's smiling. And part of our job is to really evaluate not only the health of his teeth, but how he feels aesthetically. So I break that down the same way I have for years, and I call that face, white, pink, and person. Those are the four things that I think are most important. What does the face look like? Where are the teeth, the white part in the face? How do the gums surround that? What is the pink? And then the fourth part is, who is the person? How aesthetically astute are they? How uncomfortable do they feel? Because we have to be able to address all of those aspects of them. In photography world, I break it down in 3 steps. And the 3 steps in photography world will be facial, dental, facial, and dental. Basically, face, white, and pink. I'm trying to figure out what do the teeth look like in the face, where are the dental facial needs, what white and pink display are there, and what is the gingival architecture that I need to worry about. I wrote an article years ago, and Aegis, I'm also the editor-in-chief of Inside Dental Technology, and I wrote an article in there years ago that I said the patient care philosophy first. And I always say it sounds goofy to say that, right? Because that's our job. But yes, we do forget that. We start thinking about the product and the process. And in that article, I talked about the future of dentistry will demand us as technicians and clinicians to be more astute with our patients and to have a better communication process to understand all the way that we can help a patient and all the ways we can, because there are things that we can't do. We can't fix everything. So let me move through this kind of quickly and run through these cases a little quicker. In general, if you look at this patient, you're going to see that not only is the number 9, the 2-1 an issue, but as I pointed out, the cuspid and the chipping, and you can see he's uncomfortable in his face. And the last thing I'm thinking about is how fast or how strong. That's not my concern. What I'm really thinking about is how can we save tooth structure? What's the most minimally invasive thing we can do? Because that's our goal. And the second thing that comes to my mind today is how valuable are you or us as technicians? Because I believe the more you know, the more you're worth. And the more knowledge you have, the more that doctors will seek you out and be more interested in you. Now, this always sounds kind of a boastful thing, so I hate to say it this way, but in my business, we don't look for doctors. They look for us. We have phone calls, if not 1, 2 a week, sometimes 3 a week, of different doctors from all different areas who want to work with us. And we can't. We're small. We're a 5-6 person laboratory. But we built it that way based on our knowledge and how we communicate and the team that I have around me. You can see my laboratory in the background. I'm actually in the lab today working. But my point is I want to be viable, but I also want you to be viable. I want people to seek you out, and I want you to be able to be paid for the quality of what you can do. And to do that, it's about the knowledge. So in a case like this, we're going to minimally invase some of the teeth. We did some veneers on 6, 7, and 8. Full coverage found on the number 9, which was obvious. It was already a crown there, so we're kind of just repeating what was already there. And then we're going to deal with another veneer on the cuspid, which is now going to be a lateral. Hopefully, we're going to try to make it look like a lateral. As far as the materials go, and I'm going to break down all the materials for you today. I want to be clear when I say that every material breaks. Metal ceramic breaks, zirconia breaks, lithium silicate breaks, and feldspathic ceramic breaks. They all break. What we don't talk about is their mode of failure. How do they break? Is it breaking by functional force? Is it breaking by biocompatibility? Or is it just breaking because of improper treatment and design? And to think of those things, you have to realize that if everything breaks, just making it bigger, faster, and stronger, it doesn't fix all the other problems that went into that. So on my screen, you see several restorations that are both zirconia or lithium silicate that cracked in half. So those break too. And the truth of those is I would rather they break than to destroy the remaining tooth structure, right? The goal is to protect the teeth, not to protect the restoration. So if we think of that, and we go to the megapascal concept, and by the way, megapascal is the standardized term in dentistry today for how we measure hardness. I would argue it's a really goofy way of doing that. If you research what megapascal is and where it came from, it started in the 1920s, and it started as a way to figure out the breaking point of concrete. So as we were building buildings and learning how to make them taller and higher, we wanted to know when the breaking forces were and how they would affect us. So megapascal term came from measuring the strength of concrete's breaking point. That's kind of what we use in teeth today. Doesn't that sound a little strange to you? We're using a hardness term. And if you think of the hardness, as I always like to point out, if you really understand nature, I'm going to tell you that a natural tooth measured under the same forces that we measure zirconias and lithium silicates on is about 130 megapascal. That's it. So when people tell me, oh, it's 400, it's 800, it's 1200 megapascal, that's great. I say, is it? Is it really great? Because a natural tooth was 130 if we measure it the exact same way. And to me, that doesn't really make sense. Now, I want to be clear. I use zirconia. I use lithium silicate. I even still use metal ceramics, as Jim has mentioned. But I try to use them in the right way, and I'll explain to you what I mean as we go through. So in the end, and I want to move to these cases kind of quickly, I want to go through a diagnostic process. What does the case look like? What can we do to save tooth structure, and what materials would be best? And when I'm thinking of the material, I'm not thinking of it for strength. I'm thinking of it for functionality and space. So look what I'm presented with here. This is some of the biggest challenges in dentistry for us. I'm presented with a lot of space on that number 9 and minimal space on the minimal preparations that we did. And although that's a great thing, more space is not better for us. And how do I manage this from a material point of view? What material is going to give me the right density, but still allow it optically to look like the thin restoration next to it? And that's really about my knowledge of how to choose it. So I'm going to tell you I did wind up going somewhat feldspathic on this case. Why? Because I needed to control my space with opacity. And if I picked a substructure, zirconia, lithium silicate, even metal, I'm limited to the thickness of that material as my opacified base. By using a feldspathic ceramic, I can actually use more opacified, more fluorescent materials to fill that space differently. So in the end, when I'm done, I can make one space look similar to the other space, even though the amount of space that I'm working with are completely different. And what I think we focus on, and I've showed this case a bunch of times in the last year or two, is we tend to look at the teeth. And I say, okay, the teeth are okay. But you know what I look at? The patient. Look at the difference in how the patient feels after I'm done with the restorations. Look at the difference in the eyes. And that's really what our work is about, really, and making that work. By the way, this case is probably almost 2-3 years old now, and I'll knock on wood that everything's still looking good and working well for him. But it was really about the material choices that we used for him. At the same time, as I get into larger cases and the materials become more prevalent to me, this is actually a student of mine. She was a dental technician. She's retired now, a great friend too, by the way, and one of my students for about 10 years. And before she retired, she came to me and said she wanted to redo her mouth. And I said, great, you're a technician, it'll be your last big case you do. And she said, oh, no, I want you to do it. And I'm like, but you can do that. You don't need me to do it. She said, I really want you to do it. So more pressure that I probably didn't need, but for her it was more than worth it. And what I want you to look at is when you look at her mouth and you look at the situations that are going on in there, the worn teeth, some of the chipping, a lot of crown and bridge work that's already in there, you should be thinking is what's right for the patient, not letting the material drive what you want to do to restore the case. And in her scenario, our goal would be to save as much teeth as possible, as most tooth structure as possible. But you should also notice that she's had a few root canals and she has some what I would call awkward spacing, right? Some teeth that have shifted or migrated over the years, and that's going to present different challenges without implant placement. And she's not going to have any implant placement, by the way, so we're going to have to manage that as peer supported abutments and bridges. But okay, not an issue. We have lots of materials to do that. And the same with the lower. She has some awkward spacing between the lower left side, but the teeth on the lower anterior were fairly healthy. So we're going to minimally invase those and just treat them as feldspathic veneers. So that's kind of right off the top. I know where I'm going there. Now the next issue becomes just what do I do for the rest of the case? No matter what the case is, without a fabulous prep and impression, cord pack and impression, we're lost, right? So for me, working with the quality of doctors that I do makes it lucky. This is a burn that's Sadler impression. You can see, I know the technicians out there and probably a few dentists out there that are watching appreciate this more than anything, right? When you pour that impression, I could pour that 5 times and every cast looks just as good as the first one. And that makes working on that cast so much more enjoyable because you're confident about what you're doing. So really an important part is that communication and the communication with your doctor partners about managing the tissue, if they're doing a 1 or 2 cord pack, or if they're using an X-Facil material to pull the tissue away. All those little details are things that I try to stay involved with because that's going to help me diagnose my way through the case. So the patient is provisionalized, and now it's all about the material. And I'm hoping that as I'm talking through this case, you guys are already thinking about what material you would have used to fabricate this case. You can see I've literally got some layering on it, so you know there's some layering, but what structure would be best? Should this be lithium disilicate? Should it be zirconia? Well, in the end, no matter which material I use, the goal is the same for me. And what is that? To create nature, to get the gingival coloration that I think nature has, to get that value to pop up in the mid-third, and to bring some translucencies and effect in, age appropriate for the patient I'm working on. I don't want to make 18-year-old teeth on a 70-year-old, and I don't want to make 70-year-old teeth on a 30-year-old. So I always say age appropriate, but youthful and healthy is kind of the look that we're looking for. And all the little details that go into a case like this is almost secondary to the functionality and the final aesthetic result. My job is to do the same no matter what the material choice is, but I do have to consider what material will be best for me. And the other thing that I think is important that we have to understand, I started off by saying the face white and the pink. Well, all the details that have gone into this, and I hope you can appreciate some of them, right? Look at the chroma, look at the value, look at the lights, the highlights with the light in the flash photography, look at the translucency and the embrasure spaces, the topography on the surface of the teeth. All of that stuff, as important as it sounds, means nothing until we could place that in the patient's mouth and actually see it harmonize with their pink gingival tissue and have the lips around it. And that's where our value really comes in, is when we can make it work intraorally, not just what it looks like in our hand. And there's a real difference to that I talk about a lot with photography and hand dentistry and intraoral dentistry. Overfired restorations look great in your hand. They look horrible intraorally. So this one works well. By the way, I have to point out that bicuspid is a provisional at that point. I'm not sure. I think I was doing a little addition to that one, and I took the picture when she was still in a provisional over there. But everything else in her mouth is permanently in, and at that point, it was just a provisional for some reason on the number 12. So big question is, what material did I use and why? Well, when Teresa was done, she was a happy camper, and she allowed me to show her photos after a while. It was done by right here in Staten Island with Dr. Bernadette Zappa. And what's interesting is the material that I used for this case was all of them. What do I mean? PFM, metal ceramics layered, zirconia fully layered, zirconia micro layered. So that means lingual or occlusal zirconia with micro layers very thin, a few monolithics, and a few feldspathic veneers. So it was a combination of 5 materials. And I know that sounds crazy, but it wasn't. It was done right for what the patient needed. And the reason it was done that way was because I have to take into account the functional attributes and the aesthetic attributes and what can and can't be done. Why would I choose metal? I'm sure some of you are wondering without spending too much time on it. It really was because of the spacing and the interproximal connectors, especially on the lower bridges, where I had very little interdental space, right? My connector sizes would have been very small, but I had long spans to stretch. And I would compromise using a zirconia material for that, because I would have had to compromise the connector spaces. So metal ceramic was the right option for this case down the road. So when I list my materials from an aesthetic point of view, and I'm just saying aesthetic point of view now, for me, feldspathic is still number 1. I'm still a layering guy. But I'll break down some materials for you that I use many different ways today. But for me, the number one option when it comes to aesthetics, and I want to preference that by saying, based on your understanding of the material, how well you understand ceramics and nature, that is the ultimate in aesthetic restorations for me. So anything feldspathic, veneers, or window veneers to be at the top of the food chain when it comes to aesthetics. After that, it's going to be fully layered restorations. They can be metal ceramic, zirconia ceramic, lithium distillate ceramic, but being able to have a core and layer multiple layers of ceramic material is the second best thing you can do, again, based on the knowledge that you have with ceramic material. Because let's be honest, if I use zirconia, lithium distillate, or metal, and I put one powder on it and grind it into shape and glaze it, of course it doesn't look good. But if I understand how to manage depth and create chroma inside and value where I need and translucencies, I can do a lot with it and kind of be somewhat of a magician is what our goal is, right? To fool the eye to see what nature really looks like. After that would be micro-layered materials, and that could either be lithium disilicate or zirconia, and then pressed veneers kind of go down to number 4 on that list. So I know we do a ton of pressed veneers in this profession. Not my favorite, to be honest with you. I do some for the right case and the right scenario, but I will tell you, I can't tell you how many doctors call me that know that we do refractory veneers or feldspathic veneers, and they're so interested in that, the aesthetics. Doesn't mean not to do pressed veneers. There are some good aspects, good attributes of lithium disilicate and lithium silicate for veneering material or for monolithic type materials, but they're not for every case. So again, your choice of knowing when, where, and why. And then lastly, I'd say is the monolithic world. But I even say that with a little bit of a caveat. Why? Because monolithics are getting better. I mean, I have to be honest and say that monolithic restorations from where they were, 8-10 years ago when monolithic started to where they are today, wow, they really made some amazing improvements because of the evolution of the materials and our knowledge of how to manage them. But for me, I say feldspathic is still number 1 and monolithic is still kind of towards the bottom of this small chart that I made for you guys. So all materials kind of work the same. They're all based on space and how we utilize them. And when you look at these 2-4 restorations that were done here, you could wonder if somebody didn't understand how to use the space, or if the doctor didn't prepare enough and give us enough space, right? And both of those are kind of the blame game of who did it and who didn't. So I'll tell you that ceramic really is made very simply. It's made to work in 1.2 to 1.5 millimeters of space. That's its main objective. Problem with that is we very rarely actually work in 1.2 to 1.5. We tend to work in more on implant and pontic sites and a lot less on misprepared teeth or trying to stay minimally invasive. So that means that the basic concept of where ceramics are supposed to work is kind of challenging more today because we have to have a better understanding of what the material can and can't do. Space is dominant. And if you look at these 2 restorations actually cut, you're going to notice that the space was not the problem. It was the management of the material. They were PFM, and you can see nothing wrong with PFM, by the way. But look at the density of the ceramic. It's almost 1.5 millimeters thick. It almost looks like it's 1 powder, or maybe the technician used 30 powders, but they all blended together. It's hard for me to know that. I just know that optically it doesn't work, and that's a technician issue more than a preparation issue. That's our issue. So I did replace those. This case is about 12 years old, and the patient had a cleaning, so you can see a little bit of a irritation on the tissue there. The photos right after cleaning, but I replaced those with PFMs, and we added a veneer in there too. And I always joke and say, find the veneer. But the point of it is that was basically the same space and the same material. It was just managed differently. And managed differently by me understanding how to use the materials that I have and what they can and can't do to make this work. So the basic concept of just filling that space had to change because I can't use the basic concept of an opaque or aligner, 1 millimeter of dentin, and 0.5 millimeter of enamel, which is the way ceramic was designed. I have to use it based on the amount of space I have and to manage the light optics the way I like that to happen. So in the end, It's about understanding light transmission. And this to me is one of the best examples, a photo that was taken about 12 or 15 years ago now. And basically you're looking at a natural tooth with a substructure on it. And by the way, it doesn't matter what the substructure is. It could be metal, zirconia, or lithium silicate. Whenever you put a substructure over a natural tooth, you create what we call a shadow, kind of like an umbrella in the sun. It's my best example. And if I take away some of the substructure, you will notice that the tooth lights up a lot more. More light is able to penetrate into the tooth. And I want that. So even with substructures, my goal is to figure out how to get light into the tooth. And that's either by, in metal ceramics, using like ceramic margin materials or highly fluorescent materials, or in zirconia and lithium silicate by using either more translucent materials and keeping them very thin for light transmission, or treating them like metal ceramics and using ceramic margin materials and fluorescent materials, which by the way is really the way I do it for most of my zirconia cases these days. I'm actually cutting back and doing ceramic margins on them. I've gone backwards in that. Years ago, I did it. I stopped it for a period of time because I thought I didn't need to anymore. And then when I started looking at cases intraorally, I realized I did need to do it to get better light transmission in and out of the mouth and highlight the pink part, because the light actually shoots up into the pink and highlights our gum tissue. So basically, all materials create shadow, and our job is to manage that in the restorative options. And like I said, margin materials, liner materials really help us with that in our ceramics. And best example of that is this picture here. Look at a substructure on a prep, and you can see the dark shadowing around the tissue area. And look at the same substructure with a fluorescent margin, and look how the light kind of gets up and into the tissue area. And that's really what we want with all our restorations, doesn't matter what the material is. Okay, so let me break through the materials quick, and I'm going to kind of run through this in a fairly fast pace. I'm not going to talk about dentures today, although we do dentures. In many ways, I'm working with them in many different systems, especially because I'm a big implant lab and we do a ton of implants here. But I'd like to kind of break the materials down differently for you. I'm not going to go into denture. My friend Mark does such a great job talking about that all the time. I just want to talk about the viability of it. For me, the strengths and weaknesses of every material is something that I have to be aware of. When I'm working with acrylic, what I want to tell you is I think it's the most effective material for many things. I could do full mouth rehabs with it. I could build pink support out. It's fairly reasonable compared to some of the other restorations that we work on. I can use it with implants or without implants. It could be tissue borne, it could be implant borne, it could be tooth supported. Million great options with it. But the one flaw that I think that we forget is, as anything with acrylic or even some composites, it's not a real final restoration. I classify it as long-term provisional. If you put a denture in a patient's mouth, 3 to 5 years later, the tissue has changed, the teeth have worn, it is no longer as viable, and things have to be redone or readapted. So for me, I like to classify them as long-term provisional because that's what they are. They're long-term provisionalization, even if we have to change out the teeth or reline them every 3 to 5 years. It's part of the process. We need to be aware of it, and we need to address it that way. For me, the materials I'm most excited about today are the hybrid materials. And there's lots of them, right? A lot of these nano hybrids and peak materials. And the reason I'm most excited about those materials is because they're much more similar to nature from a rigidity and flexibility point of view, or a megapascal point of view, as we like to break it down to. So for me, the strengths of these materials are they're much more similar to nature. They can actually be micro or fully layered materials, being that we can use the material and layer things on them sometimes, or put substructures over them. So that's actually helpful for us. Selection and understanding the materials is critical because there's lots of them, right? There's lots of peak materials out there today. There's lots of nano hybrid materials out there today. But they're also very millable, which is really cool for us because that does give us process in the mix today. But the best thing about them to me is two aspects. One, they're etchable. So because they're etchable and bondable, they're more cohesive to nature, and they're adjustable. What do I mean by that? Implants. Studies will show you today that every screw retained single implant has an open contact within 1 to 1.5 years. Well, if it's screw retained, not a problem. You unscrew it, send it back to the lab, we add ceramic to it. If it's cemented, what do? How do you get it out of the mouth without cutting it off? If we did it with a different material, and for me, that material is Anamic, which is a nanohybrid material, that means the doctor can actually adjust the tooth and bond to it, can add a composite contact to it without having to take the crown out of the mouth. So for me, that's a fabulous option. Plus it wears very similar to nature. I'll go back to my megapascal concept here for a minute. And one of the most frustrating things I think I hear about in dentistry today is we place an implant and understand an implant is something that has no natural movement to it, right? General tooth lives in the periodontal ligament. It moves back and forth functionally, and that's how it kind of protects itself. When you place an implant in, it's braced in rigid bone. There is no movement to it. It has no ability to protect itself. And then we push putting a 1200 megapascal monolithic material on top of it so the material doesn't break. Doesn't make any sense. I want the opposite. I want a material that's going to add the shock absorber effect. I want a material that's going to take up some of the force and wear like nature so it doesn't impact the lifespan of the implant itself or damage the surrounding teeth. And for me, that's a nanohybrid material. I use Anamic for that a lot. And we try to push all our doctors into single molar dentistry, especially into screw retained option with nanohybrid type materials. And by the way, we can make them look great. I mean, this case Helen actually did, Jen milled it, Helen stained it, it's stained and glazed in a light curing unit and cemented in the mouth. I think you can see compared to a pretty poor looking restoration next to it, it looks pretty damn good. And they can look very nice. Will they stay that way forever? No, they'll wear like natural teeth. But that's actually a good thing for me because that means it's protecting its surrounding circumstances of the implant underneath it. And I use that material a lot for these type of cases. This was an ameliogenesis case on a young girl. We don't want to prepare the teeth really at all. We don't want to really do much of anything until she's of age. So I can actually go back and mill an entire mouth of Anamic materials and bond that in, and we can use that bonded material to help move the teeth orthodontically or just replace what's there for an aesthetic long-term provisionalization. So that really works really well for us. Lithium silicates and D-silicates, again, great material. There are goods and bads to all materials. That's what I'm kind of breaking down for you today. I do believe that they're better aesthetically. And let me be clear, lithium silicate and D-silicate are similar materials, but they're not exactly the same. I get in trouble for saying it this way. I relate them as the D-silicate materials are mostly the waxed and pressed materials, and the silicate materials are mostly the milled materials. Their chemical makeup is slightly different, and their optics are slightly different. But I also want to be clear and tell you both of those can be reversed. We can mill lithium to silicate and we can press silicate. But in general, I find the opposite. Good and bad about them, layered, they're better. I do think optically the silicate is better in general from an optic and a value point of view. So we're we're designing and milling more our lithium silicate today because optically I like the material better. I'm using Zirconia for that. I could also mill out my wax and press that, and I've spoke about that in other lectures over time. But like every other material, your knowledge of understanding which block to use to mill or which ingot to use to press is really, really critical for us. And creating value. In the lab I was talking to yesterday, they said, you know, to me it's a crime when I hear this. Well, if the doctor asks for A2, we usually press an A2 ingot. And I'm like, why would you ever do that? It's the exact opposite of what you should be doing. You should always be raising the value of the ingot or the opacity of the ingot to support the value of the final restoration. And I think that's a really important part for us to understand when we're choosing either our milling blocks or our pressing materials. The good thing about lithium silicates and the silicates, they have lots of options, right? Inlay, onlay. I don't do bridges with them. I know some companies recommend that. I'm anti-bridges with those materials, but for single units, for veneers, either monolithic or layered. I kind of like them. And here's a perfect example of a case, actually one of the first ones that I ever did with the lithium silicate material. I won't walk you through all the details except for obviously crown lengthening was done, prep design, and all the normal things that we would go through. This was done through NYU. I'm a faculty instructor there for a group of dentists that travel in for a yearly program with us. And you can see how thin this material is, right? I pressed it I milled it in a very light material, but look at how thin it is. It's probably 0.2 millimeters there. And because I have a light core to work on, I'm just going to do a micro layer, 3 or 4 powders now, create some aesthetics, polish, glaze, all the little normal details that I would do, and hopefully change how the patient feels and how they see things. And again, back to the eyes. The eyes never lie for us, right? So we need to have that vision. We need to create those results. For those of you who know me, I probably always talk about photography. I'm really going to skip through the photography today just for time. But again, please feel free to email Jim or anybody at VITA or any companies I work with, and you can request that I can be specific on certain topics. One of the newer materials that I think I'm most excited about lately is some of the milled ceramic materials. And again, most people who know me as feldspathic guy, it probably sounds contradictory to me saying milled feldspathic materials, but I have to tell you, I've been loving some of the aspects of them for many, many reasons. One, they are feldspathic, so optically, they have a much better light balance of being able to absorb and reflect light based on thickness. Two, I can layer on them. I can actually mill out a base core of a feldspathic material, and I'll show you an example of that as we go through this. And I can actually layer ceramic on, or micro layer ceramic on, which is really cool. But if I do treat it as monolithic, and this is where I'm kind of pushing a lot of the laboratories to go. If you're selling monolithic lithium silicate or disilicate veneers, this is a material you must try. You will get a much, much better aesthetic result because of the density of the material and its optical presence and what it looks like in the mouth compared to lithium disilicate. So what are the strengths and weaknesses? It can be layered or it could be used monolithic. It accepts stains better than most lithium silicates or zirconia materials. That's based on the porosity of the surface. It can be adhesive or cohesive, but it works much better cohesive, so bonding, and it's etchable, so another great strength. So let me give you an example of how this actually works. I'm actually milling ceramic blocks, and you can see how thin. Sometimes Jen mills these at 2-3 millimeters. I'm like, Jen, it's so thin, I'm afraid to touch it. Mill it a little thicker for me so I can play with it a little bit. But basically, right out of a mill, you can see that I could put this right to the die. This will be a window veneer. You can see how thin it is and how well adapted it is to the die. And that's a mill and scan. And I'm doing a lot of my window veneers this way lately, where we're actually trying to fill spaces by minimally invasing the teeth, no preparation, milling out these little window shells, and then just staining glazing. So a little bit of coloration added on the surface. It gets baked into the ceramic better than with harder materials, and then a glaze and polish over that. And the 654 veneers you're looking at here are basically just milled, stained, glazed, polished. Really nice system and structure that we get a lot of nice details out of that. And I do that a lot these days when I'm not doing feldspathic. Again, not everything is for every case. So there are some times where feldspathic is way better option. And there are some times where a milled mini restoration is actually better depending on what I'm looking to do. But I also can layer on these if I'm milling it. And the material I'm milling, by the way, is called Mark II. I want to change that name to like Evolution or something cool because it's an amazing material. It's one of my favorite materials today. I have to thank my friend Bobby, who really trained me onto it a few years ago. I fought him on it. I'm like, no, feldspathic is way better, but he was right, and I'm using so much more of it today. One of the advantages of is what you see here. I can actually mill this out as a normal structure and just micro layer, right? So maybe 1 or 2 little enamel powders and finish that off. And those are feldspathic veneers that are basically 90% milled and just a very small micro layer. And from a laboratory point of view, whoever's out there listening, or a dentist point of view, it definitely increases the acceptance of the aesthetic prowess of your patients. They like it better because it looks better, it looks more real. And from a laboratory point of view, you can now bring in product and process and not to worry about only having a ceramist who can layer 30 powders to make this look real. So for me, this is a great option. I'll show you one more quick case of those, and then we'll move on to some other materials. I don't want to fall too far behind. This was a case that we just finished up last year. Normal process. Patient wasn't going to have a full mouth. They just hated some of the chipping on their cuspid and lateral. I looked at the case. One of my doctors looked at the case and said, no problem, window veneers, we could do this easy. So we won't really address anything else, just a little additive wax up on the cuspid and lateral, just to fill the spaces in the chipping. We did a wax up, we put that intraorally to evaluate it, and now it's about the prep design. The doctor's gonna minimally invase these preps, but what's really important about these types of preps with veneers, especially the minimally invasive preparations, is the elbow prep. And what I mean by the elbow prep is that as a doctor is preparing the finish line, you really need to create a little bit of an elbow that gets back into the interproximal, and then change the angle of that burr so that I'm actually going to come down and change that little angle. So you're basically just making an actual elbow into the preparation. And that's so when we build ceramic, it goes in more deep and the tissue will fill over that. You'll get a much better look aesthetically out of it. From there, we could do this with a digital impression or a manual impression. I use both today. I try not to use digital for veneers for many reasons, but this we could have done without an issue. Minimally invasive preparation. I'm going to design this in a digital world, or Jen's going to design this in a digital world. She's the digital queen these days. And you can see that the doctor has not really created a bad issue as far as path goes. He did not break the contact on the adjacent teeth and didn't wrap too far lingual, so I'll have a path either facially or incisally for my veneer, and the same on the cuspid behind it. I can actually go from the facial or from the incisal, so it makes it a lot easier for me. And then after that, everything is scanned, right? The teeth are scanned, whether it was a digital impression or a cast impression, either way. I'm going to scan, design, and mill. And those are going to be milled simply. And fit back to the die model, and then fit back to the solid model. And those will be sent back to the doctor for insertion. Those are milled, very little stain, glazed, and polished. That's all they are. Fairly simple process. And then they are inserted in the patient's mouth just to fill the areas that he wanted to fix. And that was probably about 1.5 years ago. I'll give the old knock on wood that they're still in there, still looking good. And it's a really nice solution for some of these cases. Okay, zirconia. Do lots of zirconia cases. Again, I think zirconia looks still the best if it's fully layered and if you have a knowledge of the material. I don't care about the megapascal strength, and I say even though we could use it on bridges, the limitation is always going to be connector sizes. How much connector size do we have, and will that limit the aesthetic embrasure spaces that we need? And if it does, your best option goes back to old school metal ceramics, which, by the way, I still use about 50% of my business, and I'll talk about that in my last few slides. It is aesthetically okay. Monolithically, it has gotten better. It is not truly bondable yet. I know there's lots of studies that show that we can bond it. The problem with bonding is we have to excessively etch it for a long period of time, and you're taking a very fragile material from a breaking point of view and hollowing out parts of the material. It just makes it more apt to break. So for me, the concept of etching it right now is still a little time away, but we're getting there with some other solutions in the material. When I go through my cases, no matter what the material is, I'm always trying to figure out where the incisal edge belongs in the case. I won't bore you with that detail today, but when I look at my patient, and this is Ella, she's a sweet, sweet lady, and you can see when I look at her case, first thing that I'm trying to figure out is where do the teeth belong in her face. That's the most important thing. And when I go through this slide, I'd be asking you, where do you see the teeth? Should they be longer, shorter, lighter, fatter, more out, more in? And that's a decision that we have to make aesthetically in our diagnostic process with our doctor partners to figure out what is best. Transfer of information for me, I'm a big Quace analyzer person. I don't believe in face pose for many reasons, and we can get into that in an occlusal lecture. So Jen, there's another lecture topic that we can add into our mix occlusal concepts. But for me, I'm using a quartz analyzer. For almost all my doctors use quartz analyzers these days. And the real reasoning behind that is because I'm trying to establish not only a functional, but an aesthetic plane. And when I use an ear bow, and I have to use a third point of reference, like a Frankfurt or Canfors plane, the cast becomes angled. It's not actually the way it is intraorally because you're using a reference point in the ear bow. When you use an aesthetic plane, you're getting a much straighter plane, a more natural plane, and that allows me to bring the occlusal tables up and down and aesthetically manage the occlusal table better, or the aesthetic position of the teeth better. So for me, quartz analyzers is where that at for transfer systems. And the beauty of it is, if you're not a pen person, my friend Dave has created analyzer tables and face bows for every articulator system you use in the lab today. So it makes life really easy for us to be able to communicate and have our doctors give us the information that we need. So that table reference on the articulator or on the transfer becomes critical for me, because if I look at Ella's face and I decide I want to lengthen her teeth by 2 millimeters, I'm actually taking the occlusal table on the articulator and dropping it down 2 millimeters, and then adding my wax to that. So I always have a reference of my horizontal plane, and it makes life a lot easier and more manageably aesthetic, I should say. Okay, so in the end, we're going to provisionalize, we're going to do an aesthetic evaluation on Ella just by putting our wax up in her mouth and evaluating what we like and don't like. And I hope you guys see, just on the aesthetic evaluation, she looks pretty happy. So she bought a full mouth rehab that day and was ready to start rolling. We designed, I think, 26 or 28 single unit zirconia restorations. In another webinar, I'll dive specifically into design and materials and layering with each of these materials. And you can contact Jim to do that. I know we have some that I've done already, but we'll do some new ones. I have a ton of new cases that I was looking through last night that I was starting to get ready to put in today, but kind of ran out of time. But I have so many new cases I can't wait to start sharing with you. So in my next few lectures, you'll see a lot of newer things for those of you who've seen a few of these cases before. In the end, we have 26, 28 single unit restorations. I think you're going to see a big difference in where she started and where she finished, and a really happy patient, and some rotations and things to make them look natural and age appropriate. And I love this photograph, right? That before and after of how the patient feels, what they did, and the involvement of really understanding how much they feel comfortable in their smile when they're done. Okay, the last subject I'll touch on, I think we're just getting about to where we want to be, is going to be metal ceramics. And I bring metal ceramics into it because, you know, it's funny. I think professionally, the industry wants us to think nobody uses it anymore. Well, ask some of the metal companies how much metal they're selling. There's lots out there. And again, we're probably about 50%. Part of that is because we're a big implant lab. But even on certain cases, I still feel like it's the right material. I still choose it for single central now and then. I could use a thimble coping and fully layer. And again, bridges where I have complications for interocclusal space, still a good material. So I don't care about its megapascal, although it has flexibility to it, which means it's actually a more rigid and long-term material than others. It can be highly aesthetic if you understand how to layer. You saw the first case I showed you. There were PFMs mixed in with zirconia and feldspathic. Hopefully you couldn't tell the difference of what they were. I can use it for long spans. I could use it for implants. I could use it for abutments. So to me, it's still a very viable material that I use a lot, and definitely long span bridges. But I'm going to say mostly with implants. So like this implant case that you're looking at on my screen now is a full mouth implant restoration done on metal ceramic, and I still like it for that. I'm going to just break down one case for you quickly. I have so many big implant cases that I'm starting to organize. So Jim, we have another topic there to be just implants and implant materials with pink and white. But on this particular case, our patient's name is Sean. He, I believe, was in a bar fight, if I'm not mistaken, or somebody punched him, broke his 2 front teeth. He also lost a lot of bone, so it made it difficult. And we spent a lot of time trying to figure out where his incisal edge belonged. I won't show you all the efforts we went through, but in the end, when we got some pictures of him from 5-10 years ago, we realized we were wrong where we were trying to put the incisal edge. He had a reverse curve his whole life, and we were going to build him back with the reverse curve because that's where his teeth needed to be. And we struggled with that until we had the photographic information of where he started years before this. So our diagnostic wax up was done like before. We're going to evaluate shade and color and the gingival materials that we're going to need. And this is going to be an old school case. I'm going with metal ceramic abutments here in the anterior. You'll notice a hole on one, and I'll explain why in a minute. Also a full coverage crown on the number 7, and a veneer is going to be on the number 10. So that's the 1-2 or the 2-2, depending on which system you're using. 2 metal restorations, actually 3 metal restorations were done. So 2 PFM splinted implant restorations and a PFM with a ceramic margin for the number 7 on the lateral. And then the 10 will be a veneer. Again, I won't walk you through the layering, but another specific topic, Jim, it could be just layering, right? We could spend an hour just talking about layerings and depth on 1 or 2 subjects. So I'm starting off with my Opacify Materials. In this case, with the VM13, I was actually using my CPs and my ECs, which are FET chromas or Chroma Plus materials. They're basically just opacious dentin type materials, a little bit different, but similar. Into my dentin materials, and then into a second or a third dentin material. I tend to use 2 or 3 dentins for every build I do. And then my enamel framing, in this case, I used an EE9. I probably mixed it with a little bit of a translucent dentin, maybe my TB 1M1, probably. I don't have it all documented out for you today, but not so critical. Then my mamelon materials, I tend to always use 1, 2, sometimes even 3 mamelon materials, depending on the effect that I'm looking for. Those are the most opacified materials and have a slight bit of fluorescence to them. And you can see why I'm using those mamelon materials, right? That's to control the light. So where the opacified materials are, the light's not going through. Where the opacified materials are missing, I'm bringing some of the light through the restorations. Okay, and then I'm going to come back with my enamels and start to cover over that and finish up the restorations. Add in a little bit of pink material for my first bake and fire that. I'll come back and do a second bake and a correction bake, and I'll finalize all my gingival tissue in my glaze bake. Usually it's when I tend to do it the most. And there is the final restoration on the cast, and that'll go back to the doctor. It goes back to the doctor with an implant placement jig, meaning that this little resin jig over the 2 abutments so the doctor can pick it up out of the box and place both of them in the mouth at the same time, or 5 of them at the same time. The reason we want to do that is because if he or she can't place them in that jig, we know that something's off, and all the work that we did is out the window at that point. So there's no sense in trying to figure out what's wrong. We know the verification of the cast was off. The other thing that we do with implants is we like to have what we call an implant plunger or a cement plunger. So what I'd like the doctors to do, if you're going to use temp cement or permanent cement on implants, is to place your cement inside the restoration, plunge out the excess so you don't get any of that cement bleeding down past the CEJ or onto the bone. That's the #1 cause of implant failure today. In this case, we don't really need much cement because, as you'll notice, there's a little bit of a hole in the back of one of these restorations. And the purpose of that hole is actually for a set screw. So this will be set screwed into the patient's mouth, or a lingualized screw, which means we always have retrievability and access to it. So it's kind of a nice way to manage through some of these implant cases. Final restoration, place in the patient's mouth. The pink dap's kind of okay. You know, it's hard to make individual teeth with pink, but it's somewhat okay. And he's a happy camper at the end. So aesthetically, we have everything we need. That's metal ceramic restorations. It's retrievable because we have a set screw to it, and we can really manage through the entire process across the board. Okay, so I think I covered every material there, kind of an overview for you guys. And hopefully I won't. I'll skip through that, not so important. I'll also mention that there are 2 books that are out recently that I'm in that I did chapters on. So the first one is aesthetic oral rehabilitation, and that book really focuses on veneers, bonding, and restorative materials, and I have a chapter or two in there. And then the other book is Journey to Excellence, and that's more about communication. And I also have a chapter in there about how I communicate with photography and some of the things with my doctors. So I highly suggest that you can pass those on to your doctors or get a read. They're actually good books. I'm proud to be part of them. So with that said, I'll stop here. This is my email for people if you want to email me during the week. If I don't answer it right away, just re-email me a few days later. I get a lot and I miss them sometimes. But Jim, if we have some questions in the queue, we can open it up for questions. I think I'm just about, look at that, 1 o'clock on the nose. So Jim, you can open it up for a few questions if anybody has a few minutes.
Yep, no problem at all, Peter. Thanks a lot. That was great information. A lot of things for everyone to think about. One of the questions was for your verification jig, are you still using Duralay for those implants, or is that a newer material that doesn't shrink? Or
oh yeah, so that Duralay word, that means the person who asked that question is over 40. We don't use Duralay at all anymore. Duralay is, sorry if I'm insulting somebody, I'm joking, but I still have Duralay in my brain too. Duralay is a resin that is a high shrinking resin material, so we've gotten away from Duralay years ago. We are using resin materials. There are many different ones out there that are really low shrinkage. We use one from my friend Sasha's company. I think Annex makes one. Several companies make them, they're great. And by the way, we use resins today for more than just jigs. We actually, Keon, who does almost all the implant work in here and is fabulous with it, uses resin for almost everything he does. We barely use wax anymore. So we're actually using resin to build restorations, to build bridges. We mill them or design them. We mill them, I mean, we can grind on them and shape them, and we cast our resins today. And we also use them for verification jigs, even sometimes bite references. So yeah, I'm big on resins, and we like a lot of the different companies' resins today because they're much better for zero or minimal shrinkage on the material.
Multi-purpose material, that's fantastic. Yeah. So anybody who does have questions, please go ahead and bring them forward onto the question box. Another question, Peter, would be, you mentioned the Mark II material earlier. Do you use primarily for anteriors or posteriors as well?
So, Jim, I think you know this. I sound like a company homer here, but I love Mark II. I'm pushing, the company.
Nothing wrong with that.
I want to rebrand it. I want to remarket it. I think everybody needs to be aware of this material. It's a fabulous, fabulous material for a lot of great things. I don't use it much in the posterior. I could, but I don't. I would rather be in Anamic for inlay onlay type materials, or lithium silicates or D-silicates. I like it more as an aesthetic material for personally. I'm not saying you couldn't use it for other things. I personally like it more for aesthetic veneer type materials. And by the way, not just the Mark II, right? There's the real life, and there's a few other versions of that where we have different things that we can do as far as having opacity and translucency. But quickly and in general, I'd say for me, from an aesthetic point of view, it's probably one of the most useful aesthetic anterior materials for minimally invasive or micro type veneering or veneer materials.
All right. A couple mentions here. Mark Walter says hi. Zach Lincoln says hi.
Hello to all my old friends. Good to hear you guys. I hope to see you all soon.
Another question we have is, do you have a certain go-to recipe on porcelain, I guess, for zirconia micro layering, or does it depend on the translucency of your zirconia itself?
So, trying to think of how I can shorten this answer because it's a really long-winded answer. I think the way I would say this is Jim, we need to put together a micro layer webinar so I can really dive into that specifically. But for a quick answer, what I would say is yes, I do have some basic formulas that I use based on the end result that I'm looking for. Part of that formula is not really about the ceramic. It's really about the zirconia. And I'm not a huge fan. I know that the companies push us more and more into these translucent zirconias. They're good for monolithic things. But when I'm layering, I really don't want much translucent zirconia. I want a base to work from. And what I do spend more time with in the actual layering of it is how I'm treating the zirconia, either through my design, meaning that I'm getting more support, more complexity out of the substructure to give me light absorption or light reflection, and then how I'm treating the core after it's milled with either margin materials or liner materials to give me the base that I need to do my micro layering on.
All right. So Lena says, amazing as usual. And then we have one from Dale that says, can the Anamic be dry milled? So I assume the mention that you had Anamic beyond Mark II, but Anamic.
Yeah, the simple answer is yes. With Anamic, you can dry mill it. I think it only mills dry well in one or two of the milling machines. I know Roland has a machine. I actually have a Roland here that we used to dry mill it in, although now I mill almost everything in my gearbox machine. I have two Amman mills, and we mill it wet. It can be milled dry, but it has to be a specific burr, and only specific machinery or specific software is able to do that. So it really depends on your system. We're back to milling it wet. And I'll also throw out, Jim, just for you and for everybody else who asks about it if it comes up, we don't mill it in the big puck form anymore. It just doesn't work. We're milling it in the small blocks. I know from a financial point of view, it seems so much nicer to have a puck and I can mill as many as I want. I have not had success milling it in puck, so we mill it back into the block form again.
Yeah, I think the Anamic is validated under certain systems that could be mill dry, and you're right. Usually, it's just the block form, but it's a great material. It comes in multicolor as well. So, what zirconia brand works best for bleach shades? Which I think maybe the question, paraphrasing, would be. For a bleach shade, do you start off with a white, non-shaded zirconia or other?
So I don't know if the brand is as critical as your understanding of the material, meaning the coloring of the shade. I'm going to tell you I have a really simple system. I use white 90% of the time, especially when doctors want anything from 1M1 or above. And then the only time that I switch away from white is when I'm going to be in the A2 to A4 range, which I don't do as many of these days, but I just finished a great dark A4 big implant case for Bernadette. That was cool. I'll be showing that hopefully soon. But we simplify it. We're predominantly in the, let's say A2, A1 or white. We kind of stay in those three ranges. And I would tell you that's very similar for me with lithium disilicates when I'm milling or pressing lithium silicates and disilicates. I'm pretty much in those three ranges. So if I was building new materials today, and I kind of talk to companies about this all the time, you don't need 9,000, you don't need 16 shades of zirconia. It's just silly. It's a goofy thing. You need about 4. And those 4, you could basically, if you understand value and you understand depth and you understand light transmission, 4 is all you need. As a matter of fact, I'd make the same argument for your dentins. You don't need 80 billion shades of dentin. You need about 4 or 5 that you can do almost everything with if you really understand how to manage optics, light, and opacity.
Yeah, it's a very good point as far as inventory goes. Once you get to know the materials, you really know what can work in a large range of different shades. So George has a question. On your feldspathic veneers, do you use a firing pad or a refractory dye? So what's your method of feldspathic veneers?
I'm refractory guy, so we have Abraham does all my alveolar casts here, and he's fabulous with them. And we do all day long. He's there working on alveolar casts. We do a lot of veneers, and I'm firing on the refractory dye, obviously, and I have a special tray with kind of holes in it where my refractory dyes sit into the tray, and they sit at a great angle at the right height in my furnace. So it's kind of a tray that we bought and modified. I modify them to make my refractory dyes slip in and out easily to make it easily and useful for me.
All right, and you know it's going to be followed up with what refractory material do you use?
So if I'm predominantly, I use the GC Orbit Vest, and I say predominantly because almost every ceramic works really well on that. The only ceramic, unfortunately, that doesn't work as well on that is the VM11. And if you were happening to be using VM11, which I like the VM11, by the way, it's a really nice looking ceramic, but it doesn't work well on that Orbit Vest. You would need another investment. I don't remember off the top of my head which one we use for that, but in general, the GC Orbit Vest is across the board the best one for most all refractory and all ceramics.
And then Ryan's just asking for your mill or printer, if you want to describe, let them know what brand you use, or is there a specific printer and or
we're a Mon-Gearbach. We actually have two scanners from a Mon-Gearbach. We also have 2 milling machines and an extent printer. I do have a 3-shape and a roll and mill too, but it's kind of like not our favorite. Nothing wrong with it. I know some people are really great with it. I'm sure it's fine for them. Myself and Jen, who I said is digital queen, she's just much more comfortable in ExoCAD software and working that way. And we also find transfers to be easier. Again, that just might be us, but we find when we're getting scanned impressions in and files, we just feel like we can kind of go through that one system. So I always tell people, everybody thinks I'm anti-digital. We're a 5-person laboratory, and I just mentioned to you, 3 scanners, 3 mills, and a printer. So think about that in a 5-person lab, and I spend 90% of my time building ceramic on my head. So we use technology to help our artistry. We don't use our technology to just be a fast sale and quick move out the door.
So more of a case-specific question. If they have very dark tooth preps and they want to bring the final crown to a very high value, is there a specific type of lithium disilicate, maybe translucency that you use as far as the opacity translucent level of that base?
Yeah, and this is a huge issue, right? Because although materials are somewhat opacified, let's take a white coping. Let's say I'm going to make a white, let it be lithium disilicate or zirconia, it doesn't matter. Let's say I take a white coping and I have a millimeter of space to fill. If I mill it, press it, or sinter it as a millimeter thick white coping, and I put it on a dark prep shade, I'm probably going to get a good amount of masking, right? Not a problem. But I'm also going to get an optically really dead restoration that's going to look like chalk. Now, where the challenge comes in is the more I take away from the thickness of the substructure, the more translucent it becomes, even if it's white. And when I get it down to a point where I have 5/6 of a millimeter to build ceramic in, I now only have 4/10 of a millimeter of white, which is now very translucent and allows the dark prep shade to come through. So the answer is, in simply, sometimes those materials aren't the right material to mask. Sometimes metal ceramic is still a better material, or sometimes more prep reduction is needed, or sometimes I don't care about the coping. I make it as thin as possible out of any of the materials, and then use opacified margin materials or opacidentin materials or chroma plus materials to do the masking for me. And again, that's about us being valuable, not the material. That's about our knowledge of how to use it.
All right. So Deborah Zerber says hi. Tomas Gudenek says hi. And then we have a question from Margaret. When building up with the effect liners, are you still raising the value like you are with its substructure?
100%. So I think yesterday, funny, Jim and I did a lecture yesterday for a lab, and we were actually focusing on that. I treat my substructure and my either liner or margin material very similar, meaning that I'm using both of them to create value where I want it, create light absorption where I want it, or light reflection where I want And I can break that down for you more in another program or something, but in general, yes, I'm using my liners to do exactly what I want them to do. I want them to absorb, I make them absorb. I want them to reflect, I make them reflect. And it doesn't have to be just a liner. I could do that with margin material too, which honestly I even like more sometimes.
Right. And then Scott's asking, in your experience, can the Emax force and the Emax ceramic be used on the Mark II milled blocks?
You know what? I've never tested that, Mark. So I don't want to, Scott, I don't want to give you the wrong answer. My assumption is yes, but I've never tested it. So I don't want to give you the wrong answer. I know, me personally, I put either VM9 on it or I could put Lumex on it. Predominantly, I'm putting a lot of VM9 on it these days. So that I know 100% works, but I haven't checked it with other materials just because I have so many VITA materials here.
Yeah, exactly. From a VITA research point of view, they found some issues with layering it on top of the Mark II pure feldspathic silicate material. And as you indicated, the Lumex AC, which is more of a universal porcelain, is primarily used today for the for Mark II layering, micro layering, and so forth, as you mentioned.
Or the 9, right? So I could put 9 on that
and
too.
And VM9, yes, or VM9, correct.
Yeah, and that's a nice scenario. So again, you know, it works from many ways. But I haven't tested that one, and if there's issues, then I would avoid it.
All right. So that's about it for the questions that are coming out. I'm going to show you my screen. And so I want to thank everybody for attending Peter's program. We are doing quite a few of them. And throughout the year, we probably got about maybe 15, 20 of them scheduled out with you, different topics.
We've got a lot of a calendar we went through, and I'm hoping you're going to cancel some at the end of the year because I'm going to be live in other places again. But yes, I don't mind doing them. We're getting pretty good and efficient at them, and we'll use them as much as we can. But again, my heart's hoping that I'm going to be face to face with a lot of people soon.
Yeah, no, it'll be good later this year. We're going to be able to get to that and be able to do in person for sure. And we can really start this up cranking. But Peter's been doing quite a few webinars with us. Remote learning is what we call it, VITA remote learning. Peter's an exceptional across-the-board technician, and not just a technician, but someone that can consult and help diagnose, treatment plan, and help many people out with different case work to get the ultimate patient satisfaction, make them smile even brighter. Those of you that are asking, just to kind of tie this up, those of you that asking, the workshop was recorded. The recordings will be posted on our VITA Learning website. And the CE, you will receive an email after this program that you'll need to respond to get your CE. You can visit us on our VITA social networks of Facebook, Instagram, LinkedIn, YouTube. All of these postings are on that. You can also reach Peter or us here at the office for VITA North America if you have any follow-up questions at the help@VITANorthAmerica.com website. Those are our phone numbers. Again, this will be recorded so you can go back and look at this. And then, of course, if you need to, we'll get you in touch with your local rep, whether it's Canada and or the U.S. We've done the Q&A, so if there's no further questions, let's see here. I think I have a question here. Feldspathic margins. Do you generally use the margin material?
100%, always, yes. I do almost every PFM I do is a 360 ceramic margin, and I use margin materials. I have some great techniques that I could teach on that. And by the way, I do the same thing with zirconia. I'm doing either 180 or 360 ceramic margins most of the time these days, and I'm using margin materials for that. Sometimes I might use a liner, to be honest with you, but I do like the margin materials best for it.
So it's you know, kind of VITA specific, but Peter, if you use some of the Chroma 3D Master Chroma stains, the question by Jose is he has a hard time to use the VITA 3D Master stains. Not very specific, but what can I do to make it better? We really don't have that much issue with them, but from your point of view, using the VITA Accent Plus stains or Chroma stains, any comment on that?
I'm not really sure what the question is, but what I would tell you with that stain or with any stain, the biggest keys with staining is breaking surface tension before you use it, right? So if you're grinding on a restoration or zirconia or lithium silicate, you always want to break surface tension before you apply the stain. That's number one. And that's usually by sandblasting. So really important that you break surface tension. And then two, you know what's not taught very often, Jim, especially with these paste materials today. I'm a big fan of the paste stains and things. The negative of them is because they are stored for so long and shipped, a lot of times they have a little bit of extra liquid in them. And technicians open those jars and mix it all up, and they overcompensate the viscosity of the material. So a trick, I guess I would say to the person who asked the question would be, if I open a jar of stain, the first thing I do is I dump all the liquid out and I save it on the side. Then I start to mix the stain, managing the viscosity of the stain and the surface that you're placing it to, the two keys with any stain material for getting the right application.
Excellent. All right, so I think Scott had a follow-up question with the porcelain for zirconia.
Scott only gets one. He already had a question.
And I think basically just cut to the chase. Lumex AC also works on zirconia frameworks as well, as well as spathic and silicate material. And then Hasina, I'm probably messing up her name pronunciation. She thanks you for an amazing lecture.
Well, thank you. Thank you all very much. I really appreciate it. I'm going to run back to my bench. I have a single central I have to get finished today.
Yeah, you better make some money.
Some other ones.
You better make some money.
Yeah, I have a case I have to finish up. But thank you all. Really appreciate it's so nice to see a lot of people turn out for these. And like I said, if you have questions, you could always email me. You could always email Jim and suggest what's something that would be really helpful for you, and I'll gladly try to accommodate that too. And in the end, I hope to see you guys all face to face soon for a coffee and some education. And thank you for spending some time with me in my laboratory. Hope you guys had a nice time.
In front of that window, you are picture perfect. All right. Well, I want to thank everybody for joining us today. Peter, as always, a fantastic webinar. Thoroughly enjoy the education that you provide, the enthusiasm, you know, because after all, what matters is your passion to actually help train and let people understand their work, what they do every day throughout, and how to make it better, easier, faster, quicker, and so forth. So thank you very much, Peter. Appreciate your time.
See you soon. Take care, everybody.
All right, this will end the webinar. Thank you very much, everyone, for joining us.